The content of this podcast is based on medical fact and evidence-based practice from credible, authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
One of the reasons that we started FlightBridgeED was because medicine is ever-changing. Unfortunately, the pre-hospital and critical care transport industry is usually the last to make changes, and as a company, we wanted to help point the way to better patient outcomes. What I have from the FAST archives today is a talk given by Bruce Hoffman called A Change of Heart. Bruce walks us through the evidence that shows maybe there are better outcomes for patients experiencing a STEMI if we don't rush directly into PCI. Don't we base our STEMI protocols on door-to-reperfusion times? Maybe we shouldn't. Maybe we also shouldn't buy grand pianos from emails. I'll let Bruce explain.
In 2016, there was a band in the United Kingdom called the 1975. And during that year, they produced a hit song, and it was called A Change of Heart. I want to take really probably the next 10 to 15 minutes to talk about really two recent times that I have had a very frank change of heart. Before I do that, I need to clarify a few things. I don't really know the best way to do this, but I'll just say I was roasted at the beginning of Fast 23 for making some really bad decisions. I want to bring probably a little bit more specific clarity as to exactly what happened. There was nobody from Bangladesh that I know of that was involved. I was sitting on an airplane traveling out to teach a class, and I got an email on my phone from one of my senior vice presidents. And it seemed really, really legitimate. And it basically said, look, one of our faculty members here is giving away her dad's piano. He recently passed. He was an avid piano playing man, and we'd like to give it to somebody within the university system. There's a couple of things about that when I reflect back on kind of how I got to where I ended up. Was one, I grew up, if you don't know me, I grew up in a very conservative kind of Connecticut household. And my dad had pushed all of us kids to go through and play a musical instrument. So I chose the piano, and I started playing the piano when I was very little, and I had a baby grand that I learned on. So I thought, boy, what a unique opportunity that somebody from the specific university that I work at would include me in a very specific email about, a grand piano. That just seems so very odd. So I replied back very nicely and said, dude, I would love this, right? So I go through the whole conversation. Please email this other person. So what do? I email another person. That other person says you need to contact the mover. I gave them very specific instructions on our address, where in our living room they were to put the piano. I wanted to know how tall it was, what color it was. They gave me all this information. And then they said, it's only going to be $502. You can pay us directly from your bank. And I said, yeah, it sounds good. So I put through $502 through Zelle, which is what our bank used at the time. And they accepted the payment very gladly, right? And so as soon as I got off the plane, so this was on a plane. This was an unpressurized cabin at 36,000 feet, which is why I think I made the decisions that I did. And for those of you that know me, I'm not like a super major alcoholic either. So I wish I was intoxicated and had something to blame it on, but definitely not. So the bank called me and left a voicemail. I called them back when I was in the airport, and I said, they said, Mr. Hoffman, we've flagged $502 on your account. It's listed as fraud. We just wanted to let you know. And I said, oh yeah, I totally approved it. It's going to a piano coming out of Chicago. I said, I'm really excited, and I went into the whole story about how I wanted it for my kids and yada, yada, yada. And the lady said, thank you very much. We just needed your approval, and we're going to pass your payment along. And they did. So I ended up with My wife, that weekend when I got home from the trip, she tells me, she said, I need to see this email. I need to see the grand piano. What the flip did you do? And I showed her, and in 2 seconds, and anybody that knows my wife, she's way more smarter than I am. And she said, dude, this is fraud all the way. I'm like, there's no way it's freaking fraud. I said, I know the guy, like really nice, da, 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 da. She said, Bruce, it's fraud. Trust me. So I emailed the guy and I said, you know what? I'm just emailing on behalf of my wife and I. You got to split an argument here. I think you're legitimate. She thinks you're fraud. And I get back the email that says, there's been a change in plans. We now need you to pay 15% of a deposit. We're no longer willing to give it out. Please send us over $5,000 or something like that. And then I immediately confessed to my wife, dropped to my knees, said she won the argument, and went away with an empty wallet. So that is my experience. It's bringing a little bit of clarity. So optimizing left ventricular perfusion. We're going to talk a little bit about a paradigm shift from what is really current STEMI care to what we're looking at maybe doing in the future and why that's important. I don't really have any disclosures other than to say I'm really fascinated with all things cardiology. We're going to talk a little bit about ventricular unloading, specifically left ventricular unloading. I want to also talk a little bit about what's called an area at risk. And then lastly, I want to talk about what is called ventricular preconditioning. This is something that's relatively new. We're seeing it mostly out of the Northeast in a pretty large hospital system in Massachusetts. The current STEMI care is really, you discover that the patient electrocardiographically is having an ST elevation MI. Most of these MIs are located along the anterior wall. EMS brings them into the hospital. We get them into the cath lab. There is an immediate angioplasty that happens. That's percutaneous coronary intervention. And they stick a wire down. They put a balloon over it. They crack the plaque. They disrupt that clot, and then they stent. And then shortly after that, they go up to the intensive care unit, get downgraded to acute care, and then eventually out to outpatient rehab. There's a few benefits to this model that we have found, and you can see them listed here. One, we're able to really salvage very viable myocardium that may have been stunned from the fibrin clot that was occluding the epicardial coronary artery that was feeding that specific area. Secondly, we're able to limit the size of the myocardial infarct by doing immediate percutaneous coronary intervention. And then we're able to really preserve left ventricular function and delay the onset of what we would call left ventricular or heart failure. Those are some of the benefits. However, when you look at those four exhibits, A, B, C, and D, you'll notice that exhibit A is very similar. What those graphs are showing you, and I'll show it in kind of more detail here in a minute. In exhibit A, you're really looking at the area at risk. In exhibit B, you're looking at, I believe it's like the infarct size, right? So the infarct size is much less if you treat it very early. And then in C and D, you can also see that the earlier we get to the myocardium, the less microvascular occlusion we have, and also the myocardium that we're able to salvage, the MSI, the myocardial salvageable index, is also very high if we treat it early. Those are all really the benefits. The problem is that when you look at exhibit A, the area of risk or the area at risk, the AAR, it's almost identical. Whether you treat an ST elevation within less than 6 hours, so thrombolysis via chemicals or mechanical intervention. And then you can see from 12 to 48 hours after, the area at risk doesn't really change. So that's a real problem. And interventional cardiologists have kind of labored over this for a little while. And they're thinking that it's related to two things. And the first one is this. They call it the loaded ventricle. When somebody develops an acute MI, specifically along the anterior wall that accounts for close to 60 to 70% of the myocardium, what you're noticing is that there's a neurohormonal activation that allows us to really reabsorb salt and water, and then also develop vasoconstriction. That happens on a very systemic level. And what that does to the hemodynamics within the left ventricle is this. One, you have a reduction in cardiac output and overall mean arterial pressure, but you also have and develop left ventricular wall strain. What is that left ventricular wall straining from? Well, one, it's something that Dr. Loria had talked about earlier yesterday morning, actually in the first lecture. And that is largely due to the water and salt reabsorption as well as the vasoconstriction. That stretches out the left ventricular wall and it drives up what's called your left ventricular end diastolic volume, which if you have more volume, you have an increase in pressure. That back pressure also pushes up against the mitral valve and it can really start to balloon out the mitral valve and eventually reflect back into the pulmonary venous system and give you signs of overt left-sided heart failure. So those are some of the issues with what we call a loaded LV that happens predominantly during an anterior wall MI. The other piece to this that we don't talk a lot about is that whenever you do percutaneous coronary intervention, there is something called reperfusion injury. And most of us know this because we have various tachydysrhythmias that might happen right after a patient has undergone percutaneous coronary intervention or PCI. But this is really the induced myocytic death from reperfusion. Reperfusion is not 100% innocuous, meaning there is some damage that occurs, even though overall, yes, we're saving myocardium, but the reperfusion injury, which is largely due to oxidative stress or mitochondrial housing dysfunction, that also causes really a further and worsening injury. What I want to focus on is how do we unload the left ventricle? Okay. And again, Dr. Loria talked about this a little bit earlier. There are a number of benefits that can happen if we are able to fully deconstruct and unload the left ventricle. One, you're going to have a decrease in myocardial oxygen consumption. You're likely going to have a decrease in left ventricular end diastolic volume, which is eventually going to lower your wedge pressure, right? If we have right-sided hemodynamic ability, it's going to increase coronary blood flow, which is exactly what we want, right? That's usually done during diastole. And then it's going to allow us to salvage more myocardium. The other piece that we don't often talk about that's a benefit from unloading the LV is that it really kind of delays the heart's innate ability post-MI to kind of remodel itself in response to the myocardial infarction. So what's the fix? The fix is an Impella device. So a lot of people will say, well, like, who cares? Okay, so we have a patient who has an anterior ST elevation. They're going to get brought to the cath lab. They stick in an Impella device, and then they open up the occluded vessel. Well, here's what's important, is that what we're finding is that if you maybe delay the onset of percutaneous coronary intervention, so you delay opening up the occluded blood vessel, and instead let the Impella run for a significant amount of time before you open that blood vessel, the area at risk for myocardial debilitation is actually reduced significantly. Okay, so that's what we're going to talk about in these next couple of slides, which have to do with what's called the DTU STEMI trial. So here's the DTU STEMI trial. So it's the door to unload STEMI, and this was a pilot trial that was done. Essentially, they were looking for people, and you can see the inclusion and exclusion criteria there. Essentially, they took people who are having an anterior ST elevation MI, typically ST elevation, some total more than 4 millimeters, and they brought the patient in. They prepped the patient. The patient was put on an antiplatelet and an antifibrinolytic. And then they placed in these patients in the cath lab an Impella device. And for half of the group, they literally put the Impella device in and did immediate percutaneous coronary intervention, meaning they stented immediately. Versus the other group, where they let the Impella device run for about a half an hour. Once the Impella ran for a half an hour, they then angioplastied or ballooned and opened up the vessel. And the results were honestly kind of shocking. When I first learned about this is not something that's oh my God, brand new. But this is something that I never really realized, and I don't think I ever paid attention to it, but the area at risk was actually reduced. It was less in patients that we delayed percutaneous coronary intervention on and let an Impella device run for close to 30 minutes before that procedure. The reason that I bring this up is because sometimes we get so used to saying everything about STEMI is time, and yes, time is muscle. But in this case, this is a pretty major shift from we need to get that vessel opened right away to maybe we need to think a little bit more about what we're attempting to do, and certainly the data is reflective of that. So I know after I read and learned about this, I had a change of heart, just like I did with people selling pianos from Chicago. But the real question is, have you also had a change of heart? My name is Bruce Hoffman. Thank you very much.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.